This is Dr. Shahida from National Cancer Institute, and I'm so thankful to the organizer for having me here. So today I am going to moderate a panel discussion on how much to adapt newer recommendations in breast cancer management, immunotherapy, and PARPI. So basically focusing on triple negative breast cancer. And it's my sheer joy to have some wonderful panelists with me. Dr. John Conybeare, clinical oncologist from UK. Dr. John, please come to the dais. Dr. S.K. Farid Ahmed, surgical oncologist from both UK and Bangladesh. Dr. Tazmeena Azadeen, medical oncologist from Pakistan. And Dr. Sanat Wanijasuria, clinical oncologist from Sri Lanka. So I think for the next 40 minutes, I'll be discussing few issues in our day-to-day clinical practice, and I should like to think that at the end of the session, you will get the confidence you need to handle those issues. So to begin with, a 41-year lady, she's doctor, presents with a lump in her right breast. On examination, yeah, not sure. So a 41-year lady doctor presents with a lump in her right breast, and on examination, it is about 3 into 2.5 centimeter mobile mass in the right upper outer quadrant, and a single mobile axillary lymph node about 1.5 into 1.5 cm. So she has family history. Her elder sister diagnosed as carcinoma breast at the age of 44 years. She was TNBC and BRCA1 mutation positive. So I'm starting a little behind. So starting with Dr. Tazmeena, usually what type of advice you give to your patient near close relative, the family member, sister, with a history of breast cancer, BRCA positive, and TNBC?
Is it on? Okay. So, Azmeena. For this 41-year-old woman who already has a family history of breast CA and it's triple negative and BRCA positive, in our country, if somebody turns out to be positive on a genetic mutation, then we offer cascade testing for the rest of the family members, the first degree family members, and the kids, siblings. And so if she's not tested before, then she should be offered genetic testing. The other thing is we don't have the marker status on this. So markers, we don't have the immunohistochemistry, the ER, PR, and the HER2 on this.
So my question was, this lady has a family history of breast cancer. So usually if a patient is diagnosed as breast cancer, sometimes we give with BRCA1 positive and TNBC, we give some advice to the family members as well, her sister, that immediate family members, for early diagnosis or screening purpose. So a little behind.
Okay.
Yeah.
So you're going to present that,
Yeah.
with the biopsy and everything.
So some screening. So go for some screening at least 10 years earlier, the diagnosis of her sister. This type of any advice you give?
Right. So that's what that if she had a family history and if that individual was tested for BRCA mutation, then we immediately test the entire family members for genetic testing. And so this woman who has a 3.5, depends on what, so you just started off with a lump in the breast and axillary lymph nodes. It's highly ominous because of the family history. So she should undergo the appropriate staging workup, and she qualifies for a mammogram and biopsy and all that.
That's why I
so
started
I was ahead of myself.
behind. Before diagnosis, before coming with the lump, we should advise the family members to at least have screening mammography after 40 years. But unfortunately, this lady didn't undergo any screening program from like mammogram. She presents with a 3 centimeter lump in her breast. So the ultrasonography finding shows a malignant lesion, 3.9 mm into 2.9, 29 mm in 12 to 12:30 clock position in right breast, as well as some multifocal and multicentric low suspicious for malignant lesion at 1, 10 and 10:30 o'clock position of right breast. So it is a multicentric according to the ultrasonography report. So these are the diagram that has been given by the radiologist with ultrasonography. I would like to request Dr. Farid to have a look on that.
Can you hear me? Right. Well, looking at it, it shows.
Yeah.
All right. Looking at the ultrasound findings, I mean, ideally, I would like to have a mammogram first. I don't know why that this 40 years comes into play. This patient with this sort of mass, they should have a mammogram first and then ultrasound scan. So it shows it's some lesions shown on upper outer quadrant as well as the supra-aspects. It's just not in one quadrant. It's whole of upper breast showing several lesions. And in ideal world, after a mammogram or ultrasound like this, I'd like to get an ultrasound-guided core biopsy of at least 2, if not more lesions.
Okay.
Thank you.
So yes, the patient underwent bilateral diagnostic mammogram, and that shows suspicious SOL in right breast, upper outer quadrant, 2.3 into 2.8, but no multicentricity. So my question to Dr. John, when mammography and ultrasonography reports are discordant, what should be done?
So given her young age, I'd be suspicious for high density breast tissue. And so I'd also consider her for an MRI scan with contrast to understand the relationship of the lesions within the breast and axillae.
So MRI of breast, you suggest. Dr. Azmina, have anything to comment?
I think Dr. Conavier did mention that contrast-enhanced mammogram can be offered to these patients because there are certain lesions which are mammographically occult. So the good thing is that this is palpable and this is something which is seen on the ultrasound. So if no one has to carry out a biopsy, then these lesions should be biopsies so that the verdict on the breast surgery can be made based on the biopsy if she truly has multicentric disease or not, because that would be a contraindication for breast conservation.
So MRI and contrast-enhanced mammogram is other options to exclude multicentricity. So MRI was done, and the finding shows malignant lesion that was consistent with ultrasonography and mammogram, and they also comments multifocal and multicentric low suspicious for malignant lesion at 1, 10 and 11 o'clock position. So it is a multicentric disease. And the dimension of other lesions are 1.2 cm, 1.4 cm, and another is 0.8 cm. So this is the mammogram picture. So for the surgeon. Are you happy with that? I can change the slide? Okay. So ultrasonography guided core biopsies were done from breast mass. It was IDCC grade 3, and from the axillary lymph node, it was metastatic duct cell carcinoma. And IHC, ERPR and HER2 positive, that is triple positive, P53 negative, and Ki67 is quite high, 85%. So the staging workup has been done. This is a CT scan of chest and abdomen with contrast, so no metastasis elsewhere, and whole body bone scan, negative for bone metastasis. So the clinical staging is T2, N1, M0, that is stage 2B. So I'm starting with Dr. Sanath. What other investigation you would like to advise besides the staging workup?
Shahida, the patient had bilateral axillary lymph nodes.
Yeah.
So here, only one side is involved?
Only the right side that was
ipsi-
suspicious. The
ip-
other side is
ipsilateral.
Yeah, not that suspicious.
So, young patient, can you just go back to the previous slide, please? Yes,
This one?
T2, N1. That is clinical. So we need to now do ultrasound guided biopsy, co-biopsy
Yeah,
from the breast lesion as well as the the axillary node.
Yeah, beside that, that has been
Yeah.
done.
Is that that?
Any biomarker testing you want
All right.
to advise?
All right. So what is your question now? Right. Yeah, this is young patient. Yeah. BRCA not done.
Biomarker testing, BRCA1, her sister is positive for BRCA1 mutation, TNBC patient
Yes.
case, yeah.
Is it been done? No, not yet. Have we done it? No.
So,
BRCA mutation, yes.
sorry, I didn't get that. So you'd like to advise BRCA1 mutation?
No. Since now we'll do a BRCA, and this is anyway, it is triple negative, isn't it? Did you show? It's a triple negative, TNBC, and young patient. Anyway, we will be going for immunotherapy. I wouldn't do PD-L1.
So what is your opinion, Dr. John, regarding the biomarker testing?
So I'd probably do an extended panel for genomics. So if we've checked BRCA1 and 2, but I'd also look for other potential inherited mutations. So a 12-panel, probably genomic test. In terms of PD-L1 testing, as we're in the sort of early breast cancer neoadjuvant setting, I would normally request
There's no
PD-L1.
clinical significance of doing, because we know whether PD-L1 positive or negative, there's no difference in response rate. So I'm starting with either any clinical oncologist or medical oncologist that what would be the plan of treatment for this patient, or you can discuss with the surgeon as well. So anyone can take.
Yeah.
I wanted to ask if she had the contralateral lymph node biopsy done, because you said when you started that she had bilateral axial lymph nodes. So it's imperative, because these triple negatives can be early stage diseases, but they have a high metastatic potential. So left axial lymph node, if that was not biopsied, that should be biopsied.
Okay.
And if she has a negative scan for systemic disease, including the viscera and the skeletal survey, then, and if she turns out to be positive for the contralateral axial mets, then this needs to be treated as an oligometastatic CAM, which is contralateral axial metastases. So the management, the prognosis would be a little different. The management would still be the same. We don't do PD-L1 testing on the patient. We do germline testing, as Dr. Conibir pointed, that we do extensive germline testing, because besides BRCA, there are other HRD genes which are also important and have implications. So, and the surgeon would do the clipping, so I will give the mic to them.
So, okay, points well taken. So, regarding the biopsy of opposite axillary lymph nodes, if the radiologist comments like this, it is within normal limit. They are radiological, it seems normal. Then we should go for biopsy of the node as well.
Right. So if the cortical thickness is not increased,
The
if the
cortical
hilum is
thickness,
intact,
yeah.
and all those features, then we can be rest assured. And plus, one can always do a PET scan. I'm sorry, we're talking in SARC country, but we can always do a PET scan to make sure that there is no contralateral also involvement. Okay.
Metastasis. So then, considering that, okay.
So she's only 41 years old, so there'd need to be a discussion. She's premenopausal, so fertility. So I think that would play an important role, because the direction of travel is towards neoadjuvant therapy. So given she's triple negative, T2N1, multifocal, I'd be thinking of offering her a combination of chemoimmunotherapy as per Keynote, as she fits that eligibility criteria for that study. So I'd do the workup for that. So I'd organize for her to have cardiac imaging, baseline bloods, hormone profile, cortisol, all in preparation, pending fertility assessment.
Okay. So the consensus, I think it's a common consensus that for TNBC, we should go for neoadjuvant chemotherapy, and if possible, we should incorporate immunotherapy with that according to Keynote 522. But now coming to the surgery portion, the patient is very keen for breast conservation. So my question to the surgeon, is it possible? It will be oncologically safe with this multicentric tumor, provided only one lesion was biopsied. Other 3 lesions, there's a low suspicious, but they didn't biopsy the lesions.
Thank you. My understanding is she's just got one core biopsy proven
One,
breast
just
cancer.
the 12 o'clock position.
And MRI suggests low suspicion of malignancy of other
suspicious,
3.
but Other 3.
But actually, to confirm, we cannot brand it as a multicentric, multifocal cancer because we haven't got a tissue diagnosis. So at the very outset, I would actually, if he's my patient, I would have done at least another core biopsy,
Another core
farthest
biopsy.
one, maybe 1 o'clock. If I can do 2, even better. And I have a feeling that they would probably come out as negative. And in that case, we would be very confident just to put a single marker of that core biopsy proven cancer and we leave the rest. And then patient can have neoadjuvant chemo and then we can do breast conservation surgery after completion of chemo in the form of a wire-guided wide local, anticipating that she would have a very good response.
Okay.
Thank
So
you.
with this scenario, just biopsy of one lesion. Okay, Dr. John, you are.
So the other thing was, of course, she's axillary node positive. So would you consider clipping the nodes as well?
Good question. Most of the units in UK are probably not doing targeted axillary dissections as yet, but I know they have started. And in Bangladesh, we haven't really, we know about it, but we haven't started practicing targeted axillary dissections. Maybe in future.
Maybe in future.
Yeah,
we'll
yeah,
think
ideally,
of
yes.
targeted axillary dissection.
Farid, you said now you will put a clip to the main lesion only. Is it?
Yeah.
The thing there. And I'm just asking now, if other things, she has mentioned that still suspicious lesions were there on the mammogram. But I don't know, as you said, biopsied only the main lesion, I think, I suppose. And in case now, if they are, I mean, it's sort of very close by. Now, for the patient, for future treatment, if the patient needs any, we'll say, boost to the breast, don't you think that anyway clipping other areas also might help?
No, I think we are getting a little bit confused with the clipping. We are talking about inserting hydrogel markers or equivalent something before starting neoadjuvant chemotherapy to the tumor, and the one that is only core biopsy proven. So which is why I was suggesting, instead of branding it straight away based on purely on MRI, a multifocal multicentric cancer, I would like to get a tissue diagnosis, and if it confirms another cancer or multiple cancers, and patient is very keen to do breast conservation surgery, we can always put 2 or 3 hydrogel markers or equivalent markers before starting chemotherapy, but not without doing a core biopsy.
Yeah.
All right?
That should be the standard
Thank
of
you.
care.
Yes, thank you.
But unfortunately, the only one core biopsy. But the surgeon, they had put marker in all the 4 lesions before NSCT. And regarding the planning of neoadjuvant chemotherapy, this patient belongs to a very lucky 5 to 10% of our patient who can afford immunotherapy. So we plan like that with the pembrolizumab, paclitaxel carboplatin, and the combination of AC and doxytaxel carboplatin with pembrolizumab. So this is the standard of care in this Western world as per Keynote 522. But I'd like to request Dr. John to comment for our moderately affordable patient or low affordable patient. If we can't give pembrolizumab, what should be the standard of care chemotherapy for this patient as per literature and evidence?
So for instance, if we have a patient that is autoimmune condition that precludes them from immunotherapy, then we'd still use a combination of dose-dense AC, followed by weekly carbotaxol chemotherapy, followed by surgery. So we'd essentially drop the immunotherapy, but interestingly, reverse the chemo around the other way.
So it's better to give pembrolizumab for TNBC patient in neoadjuvant setting because it shows about 65% PAT-CR rate. But if a patient can't afford, then we can go for paclicarbo weekly regimen and dose-dense AC. And there are so much and so good data. Recently, the Pearly trial from Korea, and Tata Memorial trial, the Brightness trial, that there is about 50 to 50%, 54% PAT-CR rate with paclitaxel carboplatin plus dose density. So we should go for carboplatin. We should add carboplatin with our AC PACLI protocol for each and every TNBC patient. So this is the message. So for this patient, hydrogel marker clips are put for all the 5 lesions, and after getting the NACT, Dr. Farid, how to assess the response of neoadjuvant therapy?
Ideally, I'd like to get another MRI since she had an MRI before, so
Yeah.
that would be equivalent. But as I said, I am not agreeing this is a multifocal multicentric cancer because you just done a one core biopsy. And just putting hydrogel markers on all 4 doesn't mean that I would agree that it is a multicentric cancer. And if it is a truly multifocal multicentric cancer based on core biopsy, I would be very reluctant to do a breast conserving surgery.
You think it's
Instead, I
in-
can offer her nipple skin sparing mastectomy and implant reconstruction.
Yeah.
That would give her reasonable aesthetics, very good aesthetics.
So you think it will not be oncologically safe for the patient to do BCS for this multicentric and 2-quadrant, inner quadrant and upper quadrant, both there's tumors.
Well-
So they are not proved.
Although papers nowadays suggest that multifocal multicentric cancers are deemed safe to do breast conserving surgery if he has got a tumor to breast ratio is significantly, there. The very large breasted lady with maybe 3 cancers, you can easily do 3 breast conserving surgeries, putting marker clips in 3, provided they are core biopsy proven cancer. So for this patient, I have got a bit discomfort about going ahead with breast conserving surgery because I don't think it will be oncologically safe.
Okay. But the breast conservation surgery was done with axillary lymph node dissection, and all the lesions were taken out by wire-guided localization. And the histopathology report shows a 1.5 into 1 centimeter foci of ductal carcinoma in situ in the lesion that was in 12 o'clock position, and no tumor cell found in other lesions of breast cancer, breast or axillary lymph nodes. That is 0 out of 8. So finally, it is YPTISN0. So my question to the panel is, would you consider it as complete pathological response? What is the operational definition of complete pathological response? Dr. John.
In terms of next steps, I would, given the fact there's no invasive disease left within the resection specimen, and we often see post-neoadjuvant chemo-IO residual non-invasive cells within the tissue.
So this is complete pathological response?
So by definition, I don't think it is, given the residual non-invasive disease.
Yeah.
But from my clinical perspective, I'm very happy.
So Dr. Azmina?
So there is no invasive disease, and
Yeah.
there would be no response in the in situ tumor. So this is considered as a pathological CR in this patient. As far as what you do after that is another chapter, because if she started with a keynote 522, then in that, regardless of the PCR or no PCR, the patients did continue with 9 cycles of pembrolizumab. So that one can discuss after the patient comes to you, whether she qualifies, whether she wants to continue or not. And when we have discussions in meetings from the investigators, they say that the methodology of the trial was such that the patients were subjected to the adjuvant 9 cycles. The study was not powered to look at whether there was a benefit of adjuvant pembro in patients who had a PCR. So that is something that's a debate that's ongoing, and there is a study which is looking at exactly that, whether there's a benefit of continuing residual disease, continuing with pembro, and with the no residual disease, stopping the pembrolizumab. Because the whole thing is that if you do not have any residual disease, if there is there are no micrometastases as such or viable disease, then what are you generating the immune response against? So although the principle of adjuvant therapy is completely different, but this is a debate that we have ongoing. In patients who are not able to afford, then in that situation we do not continue, especially if you have a PCR.
Shahida, I agree with Azmina. In our setup, yes, the ideal is thing to go for the up to 1 year immunotherapy. But with all these difficulties in our region, our team is for that. And even as you said, after discussing, we can even, I think, I don't know, you can give your opinion, even no treatment or even, I don't know, your opinion on capecitabine, something, adding capecitabine instead of immunotherapy, or just follow up. What do you think, Yasmina?
So according to the CREATE X trial, patients who have residual disease, or if this patient had residual disease, then I would have considered continuing pembrolizumab and even giving capecitabine with that. There are no trials which are looking at, which have supported adjuvant combination of pembro and capecitabine.
Capecitabine.
But there are trials in the metastatic setting which do not see any kind of an adverse interaction. So I would even consider escalating the treatment in those patients. As far as this patient is concerned, if you're talking about metronomic capecitabine as the CISAC 001 trial, in that 1 year of capecitabine was
Yes.
given, one can consider perhaps after discussion, it's a shared decision making, so you have to discuss with the patient. It's a low dose, 1 year of capecitabine. And in those patients, pembro was not given. So whenever you look at a trial and whenever you look at an indication for a specific treatment in the specific setting, you have to make sure that if your patient meets the eligibility criteria. So the CISAC 001 trial did not have patients on pembrolizumab. They had neoadjuvant and they had adjuvant, and they continued it beyond your anthracyclines and taxanes to 1 year of capecitabine. So, this is extrapolating and superimposing data upon data, which is something sometimes very harmful.
So, okay.
May I go back to a little bit behind, if I'm allowed?
Yeah,
Can I go back? Can I ask something?
yeah.
You just written breast conservation surgery. Ideally, it would be beneficial for the audience to show us, a photograph how the tumors are localized, like a wires or what. And after surgery, what was the aesthetic outcome, cosmetic outcome?
Okay.
Because one of the important junk part of breast cancer surgery is you need to ensure the appropriate cosmesis is achieved. If you cannot achieve it, you're not supposed to do breast conserving surgery. So it would be fantastic for the audience to give her more confidence if you could provide some photographs before surgery and after surgery, please. Have you got it?
Yeah. Sadly, I don't have right now, but I will let the surgeon team to supply this photograph to you, let them know. So according to the operational definition of Keynote 522, they have considered TIS as complete pathological response. So we can consider it as complete pathological response, but as per Keynote 522, after complete pathological response, there's recommendation of giving another 9 cycles of pembrolizumab for the patient, and if not complete response, we should add capecitabine for this patient, and if BRCA1-2 positive, then olaparib. Is it right, Dr. John?
So the trial in those patients with apathia, you're right, continued 9 cycles of adjuvant pembrolizumab. So in terms of patients who didn't have a pathological complete response, certainly in the NHS, what we would normally do is cease adjuvant pembrolizumab. It's not funded, and we'd switch them to adjuvant capecitabine. So that's in the public health sector in the UK. What's happening outside of that is to continue the adjuvant pembrolizumab and to add adjuvant capecitabine to those last 9 cycles. So interestingly as well, I believe there's data and studies ongoing looking at if she had been a BRCA1 carrier and she hadn't had a pathological complete response, adding olaparib to the adjuvant pembrolizumab again as a combination treatment post-surgery.
So, Dr. Azmina, considering this, our SARC region patient with moderate affordability, after having PETs here with 8 cycle of pembrolizumab, can we stop here, or do we have to complete the whole 17 cycle?
I think so, because we don't have data to support the
No
adjuvant
data
pembro
to
in
support,
PCR
yeah.
patients. So I think we can safely omit that.
Yeah, we should continue up to 17th cycle.
Did I hear capecitabine as an adjuvant setting as well? Because she had a complete pathological
No,
response.
she doesn't need, but
All
if
right.
there's no complete
Okay,
response,
okay. Thank you.
fine. So now it's Dr. John's, ball is Dr. John's court. This is the adjuvant radiotherapy for this patient. What should be the target volumes? And the important question, would you consider omitting regional nodal irradiation as nodes become negative after NACT
So-
as per RTOZ 1304 trial result?
Can I ask one question? So if she became clinically node negative, she would have qualified for a sentinel lymph node biopsy. She has breast conservation on one side and she has sentinel lymph node, instead of sentinel, she has the axillary dissection on. So that's kind of a discordancy between the management, so the surgical management of this patient, because we can safely do sentinel lymph node in a clinically node positive, which becomes node negative after neoadjuvant therapy.
I think we need to be a bit careful about this. Clinically node positive doesn't mean it is positive. She should have ideally had a core biopsy or at least an FNAC of the node prior neoadjuvant chemo. That would confirm she did. If she was positive,
It was positive in core
we had two
biopsy.
choices. Either you put a clip on the node,
Yeah.
in that case you can do SNB, but if you haven't done a clipping in the nodes,
Then
and you haven't
sentinel.
got the technology to do a wire-guided excision of that clip node, then you have to do axillary clearance.
Yeah. Yeah.
That is the current practice.
So currently we don't have the facilities of targeted axillary dissection, so we haven't put any marker in the axillary node, lymph node, so that's why no sentinel lymph node
So
biopsy.
a lot of times, even if you place a marker, the markers can dislodge. So in our practice, we don't routinely, there are some centers which not put a clip, but if they turn out to be node negative on an imaging, because they have pre-surgery imaging done, if they turn out to be node negative on imaging, they still qualify for a sentinel lymph node biopsy. It would be, there's always this discussion about SLN and TAD, where you have placed a clip node, but as long as your center is removing 4 lymph nodes using 2 dyes, then they're okay. A clip node would be great, but sometimes we don't have the luxury of the clipping.
I want to comment from Dr. Farid. If you don't put any marker from the very beginning and it has gone, then how will we identify that this was positive previously?
You just have to be lucky.
Sentinel lymph node
Because, no,
biopsy?
you're right. It's very difficult. If you got a very good pathologist and you got a frozen section facilities and you do sentinel lymph node biopsies, and pathologist might be able to call you instantly after assessing, yes, this was positive previously, now there are evidence showing it's negative now.
Negative now.
Then there is a possibility. But my point is, my concern is, if you miss that one, so that is why the practice, the standard practice is still, I mean, I have to say there are lots of trials ongoing where there is a complete radiological response, even of this type of cancers, and you don't do a core biopsy, and if it shows histological also complete response, a lot of centers are doing research is not doing any surgery. But I don't think just some areas, some research is ongoing, we just accept it immediately, because we get a bit shaky because we haven't got a concrete evidence as such as yet with current practice. So if she was pre-NACT node positive on the histology, then after neoadjuvant chemo, even if there is a radiological response, but surgery-wise, as a surgeon, I would recommend axillary clearance.
Axillary, you recommend axillary clearance. Okay. Dr. John, regarding target volumes, the whole breast, and would you consider the RNI for this patient?
Yeah, so she's had breast conserving surgery, so adjuvant radiotherapy would be considered standard of care. Target volume would be, so I'd offer a whole breast radiotherapy. In terms of omitting regional nodal irradiation, I would. So we've got the results last year in San Antonio, demonstrating patients who were clinically N1 who become pathologically YPN0 who have breast conserving surgery. The data would show you can safely omit regional nodal radiotherapy. In terms of dose fractionation, so alluding to my talk earlier, she'd be a great candidate for the Fast Forward Boost trial.
Oh, ultra-high flow
So she's
fractionation. Okay.
Under 50, she had high risk disease, so I would normally consider her for a boost as well. And so you could offer her fast forward 26 in 5, followed by a 5 fraction boost. Or you could offer her more traditional 15 fractions with a simultaneous integrated boost,
Boost.
taking the
For
tumor
all the
bed.
4 lesions? All the 4 lesions?
So
previous?
ideally, yes. Ideally, if they've had breast conserving surgery and they've clipped those, you would define your surgical bed as your. So I think that would be oncologically safe.
Okay, thank you so much. So this is the ending of my first case. And the second one is the metastatic TNBC. So a 39-year lady diagnosed as carcinoma breast right back in 2022 and underwent simple mastectomy with axillary clearance. The histopathology report showed IDCC grade 2 and then stage was T2N1, 2 out of 11 lymph nodes were positive, and M0, that is stage 2B. This is a triple negative case, and Ki67 was that time 30%. So the patient received as well as an adjuvant chemotherapy with dose-dense AC followed by paclitaxel plus carboplatin, and adjuvant radiotherapy, this is chest wall plus regional nodal irradiation. But now the patient presents with 2 months history of cough and respiratory distress. And the CT scan of chest with contrast shows mixed density soft tissue masses of variable sizes in right lung suggestive of metastasis. So what should be the further evaluation process? We can pick up the chest pulmonary metastasis. Should we evaluate more, or we can jump to the treatment with this report only? Dr. John.
So clinical examination and imaging to understand what's going on to cause her respiratory distress. So I didn't catch, right? She had tests to reveal what's the underlying cause. She had a chest x-ray, CT chest.
Yeah, she has CT scan chest. So they're suggestive of
Okay.
metastasis.
Yep.
So do we need to evaluate the abdomen, bone, or brain for this patient? It's a TNBC patient. There's high propensity of brain metastasis for this patient. Should we complete the staging workup at that point?
So yes, normally I'd organise for her to have
No-
whole
normally
body
you
staging.
suggest, even in asymptomatic patient, the brain MRI?
So ASCO guidelines would suggest that you don't need to, but my personal preference is triple negative breast cancer has a high risk for brain disease, so I would routinely do a baseline so we know it's clear
You routinely.
when we start.
So that has been done, and we confirmed the diagnosis in the metastatic site. It was metastatic duct cell carcinoma and TNBC, and CT scan abdomen was normal, whole body bone scan, no bony metastasis, and the biomarker testings were done, germ cell BRCA mutation positive, and PD-L1 CPA score less than 10. So what would be the management plan, Dr. Azmina?
You have a target, you use that target, you give her olaparib.
Yeah.
So previously what we used to do was use this as a second line of treatment, but now it has moved on to first line of treatment. And there is all, because there's less confidence in a pill. You know, people want big results, they want chemotherapy. So it all depends, you know, if she can afford olaparib right away and she can tolerate it, that would be the first line of management for this patient.
So olaparib is your
Yes.
treatment of choice because it's a category 1 recommendation by the guideline. But considering the SARC country, would you consider giving carboplatin because we have the TNT trial data?
Certainly. If she's had taxane and platinum before, we can re-challenge her with the same, provided that she doesn't have any neuropathy, neurotoxicity. And the decision in metastatic setting is always a shared decision-making as to what the objectives, what the goals are for the patient. If this is a working patient, her appearance is very important to her. If she has some neurotoxicity, if she has underlying diabetes, comorbidities, you know, what is her access to care, then one can consider carboplatin with gemcitabine also. Eribulin is something which is underutilized, and I've seen great results with that. So that is another option for this patient. And vinorelbine is another option. So these are certain options, chemotherapy options that we can offer to her if she cannot afford that. But this is always a challenge, you know, triple negative. It's an aggressive and a very difficult disease to attain any kind of a meaningful response. And the fact that she had a recurrence within 2 years is again an ominous sign.
So how long you
Asmina?
will, yeah, okay.
Asmina, would you start straight away olaparib here?
Yes, we can start olaparib right away. Like I said, we were giving them chemotherapy, and then we thought that as a security and safety, we'll maintain them on olaparib, but it's better to now, like Dr. Lima mentioned, that it's a category 1 for first-line treatment.
So Dr. John, you want to add something?
Yeah, so just going back to your last slide. So in terms of PD-L1 testing, so I think it's important to remember there's 2 antibodies. So we'd normally request in our center to test for both CPS and PD-L1 positivity.
Yeah.
The other thing is we also know that tumors can often be heterogeneous, and so she's had a core biopsy of one of her lung lesions. I would also go back and ask for her original specimen to be
Original
tested as
specimen,
well,
okay.
as we have had patients where we've seen discordance between a metastatic lesion test and a primary test, which can then influence selection of agent.
So,
Okay.
And now in the era of HER2-low disease,
HER2-low.
for triple negative disease, we can offer her ADCs, we can offer her TDXD, trastuzumab deruxtecan, that can be offered. And then there is another antibody drug conjugate, sacituzumab govitecan,
Yeah.
that can be offered to the patient. But again, those are not for the resource-restricted countries, if these can be made available at lower costs.
So how long you will continue this olaparib, and how would you follow up the patient when in olaparib?
So until disease response, until the patient is
Or
tolerating
progression,
for any drug as such,
Unacceptable toxicities.
unacceptable. Olaparib is tolerated quite well.
But
And the
also-
good thing is that if you have a BRCA mutation, and even if you have to dose reduce the olaparib, as we extrapolate from the ovarian trials, is that you continue to have a response in patients. So even with the lower dose, you can saturate the targets and you can still obtain a response. The important thing is to not have long delays and long gaps. As long
Okay.
as they can adhere to even smaller doses, continue on that.
Okay, I think I have to stop now. Thank you so much, all the panelists, for this wonderful discussion, and thank you, the audience, for being with us. Thank you so much.